exciting to see a full room this morning on a Monday morning. So Nicole introduced me, Renée Jacobs. I'm the Global Business Development Manager for Healthcare for Distech Controls. And I spent over half of my career working for hospitals and facilities and construction. So I made a switch and got into the controls business after that, and that's where I am today. I'd like to introduce or have our panelists introduce themselves. So I'm going to start with Doug. Go.
Well, thanks, Nicole. Doug Carney. I'm the Senior VP at Mount Sinai Health System in New York. We're an 8-hospital system, and we have a med school. And we have about 15 million square feet in the 5 boroughs in New York.
Thank you, Doug. Clint?
I'm Clint Russell, Vice President of Capital Deployment, Construction, and Equipment at HCA Healthcare in Nashville, Tennessee. We've got about 185 hospitals in about 22 states and in the UK.
Charles Shelburne, responsible for campus planning for Baylor Scott & White. We're based in Texas, the largest not-for-profit in Texas. We have 52 facilities, or 52 hospitals, plus another 600 clinics throughout North and Central Texas, from McKinney all the way to College Station.
Well, we're going to kick off the panel discussion today. There's been so many changes and so much that's happened in the last few years. And as we were prepping for this panel discussion, it was interesting to hear the different viewpoints on how we're addressing remote work and how that is changing the dedicated office space and what that looks like from a real estate footprint. So I'm going to ask the panel to just all answer that from their organization's perspective is, how are you changing office space? What does it look like? What are you predicting the future to look like for office space? And I'll let you kick that off, Charles.
Sure. So in 2017-18, we planned a new centralized administration facility. We had big plans for shared work environment. What we realized, we had 500,000 square feet in North Texas. That was at about 50% utilization. So our goal was to take that 500,000 square foot of leased space to 300,000 square foot of owned, create a collaborative work environment in which we were targeting about 65% occupancy. So we're going to have shared offices and shared workstations. Then COVID hit and changed our strategy pretty dramatically. We still opened the building in August of 2020. So we opened right in the middle of the pandemic. Obviously its own challenges, but really that's changed a lot of our mindset of how we have to approach this. Unfortunately, and one of the things we're going to talk about in a few moments is about customization and avoiding customization. Well, we customized this building. We set it up for these large floor plates where you could have this accidental collaboration. No one was within a story of each other, so we didn't stack the building. We built these large open floor plates to have that collaboration. We put our C-suite on the 3rd floor right in the middle of the building, so these folks could really interact with the C-suite, and had a very, very purposeful plan. But it was not set up for multi-tenant. It was set up for us. It was set up for one tenant. And I pulled some of these stats from last week. We're at about 33% occupancy. And what you're hearing is folks have the opportunity to work from home. They have that ability, and also they're recruited to be work from home. So you got to balance staff satisfaction, retention, and the built environment. We are looking at some opportunities to repurpose some of that space with some of our partners, specifically around medical education. There's a big opportunity there as we partner with different groups for nursing, undergraduate medical education, graduate medical education, and how that works, because we were purposeful of putting it on our campus, on our Dallas campus. So that was very helpful in that it's on campus and it is a nice location connected to the campus. And we did that originally to see the white coats and to have that connection that you work for Baylor Scott & White, and it's not a company or a corporation, it really is, you're a part of a healthcare system. So it's working out in that manner, but we've got to come up with some strategic ways, because we have a very nice building, very low occupancy, and employees want their cake and eat it too. They want to work remote. They want to be able to work from home when they choose, but they also want that dedicated workspace. So we never had the chance to change the culture. We didn't have that chance in 2020 to really have them in and create that shared work environment. So now we're trying to create a culture, change the culture virtually, and that is a challenge, because last week we had somebody there about 15% utilization of their office, and they're like, well, you don't qualify for a dedicated workspace, and they're not happy with that feedback. So that's one of the things we're seeing, and for our administrative space. We have been able to take some of those same principles and take them into our clinics. So conversations around office space, shared office work environment for clinics has been working out very well. So our physicians are listening. They understand a smaller work environment for their space versus the we space, and putting that space back towards the patient care area. And we're also seeing that in our new hospitals. So we have got a couple of facilities under planning, and even the C-suite within those facilities or the administration space, they're very open to that conversation. And it is helpful when a president comes to you and says, well, my office is too small. Well, that's great. Your office is big, your office will be the same size as the CEO's office, because within our new administration building, everybody has the same size office. We have one office standard and one workspace standard. So it does help at least that conversation when a president wants the 300 square foot office with the credenza and the desk and the more traditional law office setup. So we have been using that to our advantage as well.
Very, very fascinating how little utilization you have in your space. And when we were talking about this, people still want to have that desk where you've got your pictures of your family and you've got your things, you're able to customize it, but we can't have, like you said, you can't have your cake and eat it too. So Doug, how in your organization are you addressing that?
All the same dynamics, but in the middle of Manhattan, it's a little bit different employee response. Our office space ranges from, for just base rent, $65 a square foot on the low end to over $100 a square foot a year on the high end. So much more expensive space. So, and people are actually aware of that, and they're pretty mindful of that. Like you guys, we had just before COVID restacked and created the, what I call the nirvana of open office landscape, and then COVID hit and everybody went home, right? We're just halfway through. We've got about 500,000 square foot leased occupancy that we call the corporate offices. And, the occupancy rates, we just have inventoried those by department, and they range from the low of about 5% on peak days. And what we're looking at is not just the peak days, but the historical peak average, so that we know what the average peak is, but then also the average occupancy across those departments. And on the high end, some of the finance teams are more like 60%. But in aggregate, the building has about 2,300 assignable spots, plus all of the support spaces. And we think we will easily be able to compress 30% out of that, which is a very meaningful savings. And there are 5 different initiatives that we're pulling from the hospital to put into that 30% of recovery space. And the challenge that I see is it's not just a real estate play. There is another leased occupancy that we think we can fully move into that found space. And, that's $8 million a year of base rent that we can save. That's significant. And even with the prepayment penalty to get out of that lease a little early, we're still, through the term of it, going to save over $35-40 million. And it's real money in New York as well. So, but the other challenge, I think, which I think sounds like you guys are grappling with too, is it's as much an employee retention play as it is a real estate play. The money's easy to count, right? But one of the other things we did was really survey our people, and we got really good response rates. And what surprised me about the survey, because we've all, I think, probably done these surveys either systematically or anecdotally, but what surprised me about these results was the employees, at least in Manhattan, had shifted from what you described to flexibility is more important to me than an assigned spot. So that we focus person for the office seems to have evolved in Manhattan. And what I attribute that to is the high cost of commuting and the high cost in time of commuting in Manhattan. Before COVID, it was routine, absolutely routine. Kind of blew my mind because I'm not originally from Manhattan. It was routine for people to have 90-minute commutes each way, normal, right? And there's no parking. You're doing all this in transit. So, so the idea that they can avoid that is a real improvement in the quality of life. And the challenge, I think, for all of us is how do we lead in a context where people, you alluded to it, how do you drive culture when people aren't physically there to do it? So those are the things when we're right at the point where we're turning the corner from data collection and analytics to, okay, how do we implement this? And that's what I think is going to be the real challenge for us, is how do we create this, the sentiment in the employees appears to be there that they want it. And how do we leverage that to make the office something that they want to come to and that they have the experience that they want to stay connected and engaged. The engagement surveys are important to us like everybody else when they do come to the office. And how do we set managers and leaders up? And one of the things we've identified is we're probably going to have to teach leaders and managers how to lead and manage in a different way, so, and that's the most frequent feedback we get from the middle level managers. It's like, I don't know how to do performance appraisals for somebody I see once a week, so it's an interesting time. I think there's a real potential savings, but I think there's also a really tremendous opportunity to create an engagement, a stronger engagement with your employees than might have existed.
So Clint, you said that most of your staff is still coming into the office every day and you have that face-to-face engagement. As you're leading the construction and planning for new hospitals, are you changing any of the office space needs within the hospital, or is that, since those are clinical folks, is it pretty much staying the same in the actual hospital outside of the administrative space?
Yeah, in the hospital itself, really the office space has remained the same for us in what we design. All of those folks that have an office in the hospital are supporting people that can't work from home. So they're going to be at the office, in their office every day in some form or fashion in the hospital. So that hasn't changed that design. I've not seen it change yet. You mentioned culture, and for our office, that's something that we've espoused quite a bit. About a year ago, our CEO said, okay, we're all coming back in the office. And what that translated into for a lot of departments is a 3-2 hybrid. So they'd spend 2 days working from home. But I did have somebody that had spent 2 years at home, working from home. One of my first meetings back after everyone came back to the office and said, hey, when do I get promoted? And I kind of chuckled because I thought, well, I haven't really seen you for 2 years. So that's one of the things that's kind of driven our outlook in our department is that culture of being around each other and working together. It's important to us. Now, there's some departments at HCA that have a little bit more lax work from home schedule. Ours has really been 3-2 for the people that are kind of transactional, the project accountants, project assistants. But everyone else really comes into the office every day. And part of the reason for that was my belief that we're supporting nurses that can't work from home. We're supporting doctors that can't work from home, the admin team. I mean, we support project managers and superintendents that are working on our projects. And so there's an expectation that, for the most part, everyone's coming into the office. Now, there's a lot of flexibility in that. It's certainly, I'd say, more flexibility than prior to COVID, but that's what's kind of driven our outlook on work from home and being in the office.
So in the early 90s, I was building a new hospital, Greenfield Hospital, and our biggest conversation was, are we going to build the rooms with inboard or outboard toilets? So we believed in 1992 that within 10 years, we were going to start seeing where all the rooms in the hospital were going to need to be ICU rooms. So we built the toilets on the outboard side so that we could take out the walls and create all ICU rooms. And that hospital is now an HCA hospital. It changed hands into HCA. So in design, and this is really, I'm going to give this to the whole panel, are you seeing where you're trying to have acuity flexible rooms as you're building new facilities, and as you're future proofing or trying to design for the future? I know that hospital still today doesn't, there's still med surg rooms. So do we believe that in the future we're really going to see that point where we need those acuity flexible rooms? I think, Charles, you have a lot to say about that.
Yeah, so in the state of Texas, we're fortunate because we have a universal bed license that we create for med-surg, ICU, and intermediate care. So that gives us a lot of flexibility, but also when you think about the patient care environment plus the future, they do stack together, because a universal room, if you're not aware of this is basically an ICU room with a private restroom. So it gives us that flexibility because most of the ICU patients don't utilize that private restroom, but their visitors do. Their patient loved ones, their staff, the loved ones do. And many times the loved ones are the ones filling out the HCAPs. And they're completing the surveys and providing the feedback that directly impact reimbursements. So that's the balancing act. What we've done pretty successfully is sized our rooms with a standard, what we'd call mid-board toilet. So not inboard, not outboard. It does create a longer bed unit, but it creates a nice rectangular square room for us. Then the two restrooms are mid-board. In between the two rooms, head walls are separated. So it gives us that ability for that direct visual point of care. Also, I think the other piece of this, and we're seeing a lot more that our trend is intermediate care. So it's not necessarily ICU and it's not necessarily med-surg or tele. It is that intermediate care, that step-down unit, some folks like to call it. So it gives us that flexibility that patient then can be located within that group. So universal care, I'll share with you, when I first heard about this was actually at a Hillron presentation, probably 25 years ago. And the concept was the patient would stay in the room and throughout their continuum of care, and then the nursing staff would change, or the nursing staff would care for them as they go from ICU to step down to med-surg. Well, the staffing does not work. So when we create universal rooms, we're creating universal units. So that unit can be an ICU, and then in 2 years, it may be a med-surg, or it might be an intermediate care, all pending on the volume coming in and the patient type. So it's gone away from just this one single room that gives you that ultimate flexibility. The patient never has to leave, to a more of a efficient staffed model that you can then fluctuate as your demand needs, not on a day-to-day basis, but on a year-to-year basis. The other thing we've done is we've been looking at some of our more aged facilities and looking at some of the what the past us have done as far as construction and planning teams. You know, cruciform, double-loaded corridors, even as recent as the 1980s, where we had a cruciform design, which was very custom to healthcare. So as you go back and look at some of these older facilities and say, what needs do we have? Administrative spaces, support spaces, those double-loaded corridors and those cruciform, those very narrow hallways really do not allow for any other use. So procedural spaces, surgery spaces. We did get creative one time and did put an OR suite on one of the kind of narrower in a double-loaded corridor configuration, but it's not the most efficient. It was, beat to fit type concept. So as we're looking at our new facilities, we've got one in Waxahachie, we've got one in Plano, we're building a new facility not too far from this location. They're all going to be very simple, very beautiful, but very simple rectangles. And I know that's not what a lot of designers like to hear, but you have the opportunity to really create a nice environment, not a too elaborate environment, but it creates an efficiency that we can then flex for patient care, we can flex for procedural space, and we can try to protect ourselves from what the future may hold. Because if we've been hearing this 20 years, less patient beds, more ICU. But that still, in Texas, I don't know if we're going to see that. We have 11 million people coming to the state in the next 20 years and up to 10,000 predicted beds. I mean, it's just going to be, how do we keep up? So our goal is to create as much flexibility as we can, encourage shelling of space versus building out of space to create that future flexibility, and keep it simple, honestly, and be creative, but also keep it simple with what we know works.
Well, you were being kind. You said 20 years, and I was aging myself earlier to 30 years, so I thank you for being kind on that. I'm going to shift a little bit. Doug?
I want to jump in on that. So
Sure.
I really think you hit on some really important concepts. In the prep session, I mentioned a colleague of mine at CHOP in Philadelphia, and I'm a recovering architect, and he's an architect too. And we started our careers designing hospitals, and when we were planning the new patient tower at CHOP, which they've started construction on now, we had this debate, right? As what kind of room should we put in there? And where we ended up was that they should be all ICU rooms, not because there wouldn't be med-surg rooms, but because we needed to transform the CHOP enterprise from what was about 30% ICU rooms to closer to 50% ICU rooms. But one of the key things that came out of that conversation was NICU, PICU, CICU, essentially the same room, just different equipment. And that was a sea change for us because when you can do a 500-bed tower, trying to dial in exactly how many of each. We had, I'm not going to name names, but we had one unit that always overestimated their growth and never hit it. We had one unit that got it right, the Goldilocks solution, and then we had one unit that critically underestimated their needs and frankly was a bottleneck in the organization. So what we did is we separated them with shell floors, just like you talked about in between. But one of the interesting outcomes of that analysis was he and I went back, we both graduated from architecture school in the same year, and we looked at every ICU room we had ever designed or been a part of. And the only thing that changed was, there was the debate, right? Most toilet rooms ended up outboard. But the only thing that changed was the size of the room as the guidelines changed. And we realized this is not rocket science, right? We are over customizing these things that are very expensive to create. Make that durable shell that's going to last that 100 years that we've talked about, and then let the equipment change and surge and create the framework that supports that. So I really wanted to reinforce that concept that was discussed.
Thank you, Doug. Very well said. And so now I want to shift a little bit and talk about a lot of the innovation that HCA is doing. And I would say from the outside looking in, we're one of the most progressive organizations when it comes to prefab and AI and how you're utilizing all of that. So how are you using AI? What benefits are you seeing? How are you incorporating that into your projects?
So I want to start with prefab because the two will tie together for us. We try to prefab as much as we can. We're prefabbing head walls, bathroom pods, mechanical racks, exterior walls, and we've got a number of things that we've tried and failed at. I mean, one of them has been casework. We've done some entire freestanding ERs. We've done 5 of those, and we're trying to do 5 more. That prefab and trying to inject prefab into everything that we do has really helped us out, especially in some of the larger cities where labor is really hard to get. And everybody knows the benefits of prefab. It's better, faster, smarter, right? Better quality. But that prefab program of really trying to incorporate everything in the hospital that we can has helped us out with pricing and labor in a lot of different markets. So you asked about AI, and one of the things that we started looking into last year, we found a company called Doxel. I think we'll hear from them later on today. And we tried them out. If you're not familiar with Doxel, so really it is a software that integrates your existing construction by taking a camera on a hard hat, walking around the site once a week. So they take that video and compare it to your schedule and to your model. And so it gives you a really good representation of where you are on your percent complete on everything. It could be EMT, it could be studs. So we tried it out last year on, I think, 5 different hospitals. And some of the response that I got from superintendents was very similar to prefab. So prefab in the beginning, most superintendents, when we say, okay, we're gonna prefab this and prefab that, they've told me at the end of the project, I didn't really want to do it, but thank God we did, or I wouldn't have made my schedule. I got some of the same comments out of Doxel and AI, which was, I was kind of resistant to this, but boy, did it help us out. And where it helped them out is getting rid of a lot of those disputes with subcontractors. So now, as one of the superintendents mentioned it to me, was imagine you're in a subcontractor meeting and you're talking about percent complete, and you've got a sub that says, well, I'm 50% complete. And now you can say, well, not only are you not 50% complete, you're 35% complete. It's taken you longer than you said it would, and you've used more people already. So we've got to talk about a plan to get you back on track. So it gives them a lot of insight into the actual progress of the job, as opposed to walking the job and saying, okay, I estimate that we're at 55 or 60% complete. That is a huge tool for the folks on site. The other thing it does is it helps us, the folks that aren't on site, get a better idea of where the project is. So obviously most people are completing their billings based on percent complete, and now we can compare what's in the invoice to really what's said using the AI software. It does a couple other things as well. It gives us really good as-builts. We haven't completed that yet. We started it last year, but we like the results so much that we committed to 3 more years of using it. Every year we touch about 3 million square feet, whether adding square feet or renovating. So we signed up for a couple million square feet a year of utilizing this software to help the project teams. So it gives us a better look into as-builts, which is something historically we're honestly terrible at. We're terrible at capturing as-builts and using them in the future. What we hope it's going to help us out with along the prefab front is being able to measure prefab. So we measure prefab right now based on man hours moved off-site. We started a project years ago, and the entire project team got together really before design started and said, okay, we want to prefab 60% of this site. How do we do that, and how do we measure it? And the best thing that we could come up with was man hours moved off-site, which is really the premise of prefab. What we think is that Doxel and other AI can help us look at prefab volumetrically and really figure out how much are we prefabbing and figure out where it works well. And then lastly, what I'm really hopeful it can help us do is understand our quantities better. We use a group purchasing organization called Health Trust, and about 39% of the materials that we put into a project are available on contract or have been negotiated through this GPO. So if we have this software that's telling us exactly how much material is being used in our hospitals and in our projects, it gives us a lot more leverage to understand how much we're buying every year the next time that we go to negotiations with the folks that sell us materials.
So I love technology, and where we're getting with technology is really, in my opinion, where I tried to be many years ago, but we're getting there. It's exciting to hear how you're leveraging AI to literally just transform your projects. So again, we're going to do a little bit a shift. We're trying to cover a lot of topics, and at the end, I'm going to make sure we leave enough time for some Q&A so everybody in the audience can have their opportunity to ask questions as well. But Charles, as we were talking, you said that there is a definite challenge between the state of Texas and CMS and their rules. And so how is this affecting your projects, your occupancy types, and then what are some of the challenges you're facing around that?
So I get a couple of things we've been working on. So state of Texas likes to do everything a little bit different.
And bigger.
Yeah. We are, I think the next round of our architectural guidelines will be adopted. Prediction is first quarter of 24, but we've heard that since, 2018. So we'll see if that actually comes to fruition, but they are aligning with the FGI guidelines much closer now. So that's a great opportunity for us just to get a little bit more standard, but we always do things different. One of the things we've seen, however, over the years is we've doing our Joint Commission inspections. They've encouraged us to create business occupancies within our hospital for the non-acute care space. And it's a line that says this is the area that you don't necessarily need to inspect as thoroughly, especially for life safety reviews, as the rest of the facility. Well, the state of Texas sees that as 2 separate occupancies, sees that as a physical barrier separation with a requirement of a 2-hour fire separation. And then if it's a different tenant, you have to separate mechanically and electrically. So then that's obviously a significant cost. So we've bumped our head a couple of times, but we've also got some clarification even since the last time we've talked, because we're building a new facility. We've talked about how do we create a business occupancy, because as you guys are aware of, atrium spaces and smoke evacuation cost are, things we try to avoid. So they have given us a little bit of flexibility with some of the dietary components, but some of the ways we've handled some of our older facilities, they're not going to do that because we just have such a hodgepodge. So if we do that, it has to be very purposeful, and we have to be very open book with the state and how we actually lay that out, and they understand exactly what we're trying to do, because it's a balancing act from a Joint Commission perspective and then from a design and state of Texas for their architectural review group. The other thing we've seen, and this came up, it's only kind of, let's say, bite us once, is around occupancy type for our clinics. And clinicians, as you're very aware, they don't understand the type of space they sit in today. So if they're a primary care clinic, you ask them their occupancy type, they're going to say they're a clinic. And then you say, well, there's only three options. Are you ambulatory or are you business? Or are you acute? And obviously they're not acute care. So they're going to say, well, clinic, I'm probably ambulatory. Well, that then all of a sudden kicks in another layer of scrutiny, especially around our HOPDs. So we've started to educate folks of what is acute, what is ambulatory, and then what is business occupancy so they can answer those questions correctly. And then internally, what we've done is we've got all of our HOPD, which are connected to any of our facilities, and started to review what we are going to define as ambulatory. So the CMS recognizes that as one person unable to self-rescue. So we've drawn that line. So obviously pain centers, endoscopy centers, ASCs are pretty easy ones to identify, but it's the memory care, it's the geriatrics clinics, even some of the the hyperbaric chambers. So you think about, can that person, are they a self-rescue? Can they customarily self-rescue themselves, get up off the procedure table and walk out? And if they can't, we're identifying that as ambulatory. And while there's not a lot of requirements, it's mainly a separation requirement, exiting requirement, maybe a sprinkler requirement, that gives us a little bit of a belt and suspenders approach just to make sure we're locating these clinics and HOPDs that need to be within an ambulatory care space. But ambulatory is not ambulatory surgery center, it's just that definition around those three key components. So we're trying to educate ourselves and educate our clients or our end users. We call them clients because we are working for them, we're their support. So we're trying to educate them and then make sure they're in the right environment and able to answer those questions, because if Joint Commission comes in and asks that clinician and they give a little bit different answer than we were expecting, it creates another level of scrutiny. And they are starting to look at some of our HOPD locations a little bit more thoroughly. So it's something we're trying to be really prepared for.
So a little bit different than regulatory, Doug. You have New York, it's a pretty heavily charged union environment. So you've got a lot of challenges around manpower. And what are you seeing? Are you seeing that getting better, worse? How are the unions helping to address manpower issues?
Sure. I've had experience now in three major Northeast markets, Philadelphia, Boston, and New York, all three of which are unionized environments for the work we do. And, the skilled trades are just, I think my colleagues would agree, just remarkable, the work they do, the pride they take in the work that they do. And, to a person, they get it, right? They understand how important what they're building is and how getting it right is. But to your point, there's not enough of them. And in Manhattan and New York right now in particular, there's still a building boom despite interest rates. And the institutional market is less affected by interest rates, but the commercial developers are not slowing down at all. New York is a bifurcated market. It's largely non-union for residential projects now. That happened probably 10 years ago. Philadelphia and Boston are still heavily union. But even at that, there's not enough capacity for the work we need to do. So the prefabrication work is helping. But the unions are trying to address that with, opening the pipeline up. But I think you also find that there are less and less people that think that, being an electrician or being a plumber is a desirable career, despite the fact that it, pays really well, but it is hard work. So I think it's a problem that's here to stay. I think it's a rate limiter for the urban areas, certainly in the Northeast. I think it's the biggest challenge for the unions for their future. It's one that we look to solve with partnerships, trying to support where the unions want to, stay, I would say, in control of the market and where they're a little bit more flexible and really try and help them help us, because I think what's so important is the craft labor that is critical for the complex buildings we do. So.
Well, I thought it's,
I think we're going to see more robotics too. We didn't talk about robotics as an AI, 'cause it's arguably automation, but I think it's one of the things I'm most fascinated by. That now, and we've all seen them. The robots that can lay concrete. There's robots that can lay brickwork, and some of the more manual, more difficult tasks are possible to automate. And when you combine automation in the field with prefabrication, I think we're going to see some pretty exciting stuff.
looking forward to that. And one of the most interesting and I would say supercharged topics when we were prepping for this panel was around ESG. And the Joint Commission recently issued a leadership standard, LDO 50101, around reporting around greenhouse gas emissions, decarbonization. And when we started talking about that, boy, was there a lot of conversation on our prep calls. So Clint, I know ESG is a major initiative for HCA, and I was really surprised at your 95% recycle target for your construction projects. What else are you doing? How are you measuring that? And what are you doing in the whole ESG space?
So that's a lot.
That's a lot. There's a lot to unpack.
ESG means a lot to a lot of different people, and there's certainly an entire team at HCA that's working on ESG in really every aspect of it. I can't speak to all of it, but one of the things that we talked about was our goal and our mandate that each one of our projects recycle 95% of the debris that comes off of the job site. So we started this probably about 10 years ago with the same mindset that we had for prefab, which was let's do as much as we can. It is certainly a stretch goal. 95% on any project is a lot, and it's tough to get to. I would say probably the biggest barrier is really the city that you're in. So, we are in a lot of urban areas, and that's what we've run into the most is actually a city that has the infrastructure to recycle that much debris and has the companies that are willing to do it. We've run into some cities that only allow one waste company, and then when you've got that, they had almost zero recycling. Now, we infrequently hit 95%. I don't want to say that 95% of all of our projects gets recycled, but we hover somewhere between 60 and 70% each year. And I don't think that we would have gotten there if we hadn't put that stretch goal out there of 95%. But it's certainly city by city, it's company by company, and it is based off of the measured weight of the debris that comes off site. You've got a couple of different dumpsters at least with a lot of different recycling types, whether it's steel or concrete or really everything else. But that's how we manage it. Is we ask all of our teams to strive for 95%. It's one of those things that they've got to set up at the beginning of the job and try to figure out how they're going to make that happen. And it's been very successful. When you consider the last 10 years and being able to recycle almost 70% of every project across the board, it's impactful.
And I live in Kansas City, so Boulevard Brewery is a zero waste facility, and I got to tour it when I was trying to figure out that exact issue in Kansas City for one of my projects. And I was fascinated with how they were actually able to accomplish zero waste for a brewery, so it's impressive. Doug, when we were talking, you mentioned on the East Coast, obviously, there's some really aggressive legislation around decarbonization. What are some of your challenges, and how are you addressing those challenges?
Well, first I have to say, as a quarter Irish person, I use a brewery as an example of zero waste. There's never any wasted beer in my head. Just
Not in our household
just got to
either.
lay that out there. But it's interesting, again, seeing three different cities. New York was first, Boston's a little behind, and Philadelphia's catching up, all of which have very similar legislation about energy utilization, sourcing of energy, and carbon neutrality. And the challenge, I haven't talked to anybody yet, and if anybody here can say they can do it, I definitely want to talk to you. But, the physics doesn't match the legislation right now. So, I think everybody knows hospitals, and especially academic medical centers, like I've experienced, are energy intensive. and, I think we would all agree, have a certain amount of life safety critical energy needs, right? And, the idea, like the thing that bothers my engineers the most is having a single point of failure, which would be, in this case, the electric grid, in an all-electric world. Let's just, I don't think anybody's arguing that we need to address the problem, so don't hear it that way. But, just tying us to the electric grid in the Northeast really doesn't solve the problem because, I was with an expert last week who was saying that, 80% of the generation in the New York grid is fossil fuels. Now it's cleaner than Pennsylvania, which has 53% coal, right? Still to this day. So this idea that electrification is going to solve global warming is just, it's a myth. But I get the premise. And so we worry about it as a single point of failure, and the physics doesn't exist, and there's no transition plan. So very, very nervous about all those things. One of the reasons I signed up to talk to NextEra is because for personal reasons, I know they're a really progressive company when it comes to renewable energy. I want to understand how they do it, how they might be able to help us. For those of you who are more expert than me, one way you can comply with these laws is by buying, renewable energy RECs. But, New York is tying with the idea that which is what I have always thought is buying a renewable energy REC, NextEra, but buying a renewable energy REC in Florida doesn't really solve the microclimate in New York, right? But so they're considering legislation where you can't buy RECs anymore. You have to physically comply, which makes sense to me, but again, the physics doesn't match that, right? So, there are some really major initiatives with Quebec Hydro and some renewables upstate in New York that are really interesting, but I think it is the most vexing problem of our time. And it's not just about the compliance issue. All three AMCs that I've been associated with were doing the math and saying, is it less expensive to just pay the fines than it is to try and comply and create risk in a high reliability organization? And the counterpart to that was always, yeah, but we can't be the entity that's out there saying we're not going to comply with this because of the PR components of it. So I don't know how it's all going to work out. My personal opinion, and I've taken a position of advocacy for this, is we really ought to look at healthcare as a unique occupancy. I really did have one of the, and I say this in the kindest possible way, one of the ideologues tell me that, well, can't you just design your hospital like a passive house? And I was like, no, it really doesn't work like that. But, for example, I've always thought that, let's do a 20-year carve out for hospitals and let us do, CHP plants for 20 years. I can amortize the cost of a CHP plant over 20 years. It's the most clean technology we have today. And then make me guarantee that I'll take it out in 20 years, right? And that isn't going to solve the problem, and it's going to be unfair to the office buildings in New York. But at the end of the day, it solves the reliability, it improves the grid, and it moves us in the right direction. I'm a football guy, man. Remember what Vince Lombardi said: if you always get 3 yards on every play, you're going to score every time you have the ball. So let's move it down the field. Let's not try and throw the Hail Mary. We were in the Star yesterday, and we found out that Roger Staubach actually said that. He closed his eyes and threw the ball and said a Hail Mary. So, world according to Doug.
Here we go.
I want to add on to, you talk about the physics of it. And last year, we started tracking on some projects the embodied carbon involved in the project because I wanted to understand it. And to be fair, we had not done anything. We're just tracking the embodied carbon. And for every project that we started looking at, over 80% of it is mostly concrete and some steel. I mean, it's overwhelmingly concrete.
Yeah.
So again, you talked about the physics of the thing, and a solution was brought to me of, hey, there's a different concrete admixture that can probably get rid of all this.
Yep.
And my thought was, okay, that's great, but I want to see it in application. I'm not going to start putting that design into our buildings, our newer buildings, without really understanding first that it works and works well. I mean, I don't want to put anybody in any danger, and it's something that I've got to see tested and tried and true before we start implementing it. Sorry, just wanted to add that.
Yeah, no, that's a good point. That we talked about this. I taught that at Drexel, and the positive admixtures will really buy down your carbon because just creating the Portland cement is intensely energy consuming.
Charles, Texas is totally different than the East Coast, and
Texas is different than everything.
everything, absolutely. Anything you want to add? How are you addressing ESG?
Well, I'm not engaged in that just personally, but I can tell you what we have been doing for the last 20 years is we've been looking at our utility cost, and we've been very mindful of that and investing in that opportunity to reduce those utility costs. Of our projects, we probably have 150 capital projects ongoing at any one time. About 145 of those are going to be renovation projects. So investing in the opportunity for LED lights, more cost-effective and efficient systems, VAV boxes. We've also worked with our facilities, shut down our ORs when they're no longer in use, so some occupancy sensors, some things that the industry's going to, but it also benefits the healthcare system because it gives us the opportunity to reduce that operational cost. So they're pretty easy sells. Many of these have a 1.5 year, 18-month payback. And so when you're talking to the C-suite and you're talking about, okay, yes, we need to spend money on something that's not directly related to patient care, you can give them an internal rate of return, and you can say there's an opportunity plus the benefit of the environmental aspect and the opportunity to improve that. So that's some of the things we've been doing to try to make sure we understand that, are not just our first run cost, but our long-term cost, and then the systems investment to encourage that.
I think that's a really important point that's made too, because folks will often say, well, what are you doing about the conservation side of this? And almost every hospital system that I've been aware of is aggressively doing the kinds of things you're talking about, and have been doing it for 10 years. So the ESCOs will come in and say, hey, we can save you money by doing, it's essentially it's a financing mechanism. And they get frustrated because we've already done all the low-hanging fruit is done, I just had presented to our board last week, and our energy utilization index, for those of you who know what that is, it's kind of the gold standard of measuring your consumption of energy, is about 240, and it's the best of any hospital system in New York right now. And we have some pretty old buildings, and I take no credit because I haven't been there that long, but it has been a 10-year systematic approach to doing all the kinds of projects that you just talked about, which is I can save money on that lighting, I can save money on that air handler, I can change those VAV boxes. It's a lot of controls, to optimize. Again, the regulators are well-meaning, but I have actually I've had one ask me, well, why can't you just set it back at night and not use energy? I'm like, it's hard to send the patients home. That is the goal, but it doesn't happen every night, right?
Well, we have just a few minutes left, and I wanted to make sure we had an opportunity for members from the group here to ask questions. So any questions of any of the panelists? And the lights are really bright, so if I don't catch you, please.
The first one's always the hardest. That breaks the ice, though.
Oh, we have someone. Oh, I know who this is. Hi, Pete, how are you? All right, I'm coming. I just want to get this on the video, so.
Interrogation.
You started out the conversation with regards to the workplace, and most of it was focused on the corporate side. And I know, Clint, you mentioned the clinical side. You hadn't changed much in terms of standards. Kind of curious to see whether any of you have made headway on the clinical, not the workspace, but the office space of the clinical side of the house in terms of moving away from dedicated spaces and moving to more agile hybrid shared spaces?
Well, we'll see is what I'll say. The initiative that I mentioned, one of the 5 occupancies that we're hoping to move into that corporate location in a hybrid setting are targeted administrative folks in the clinical setting. And, when I mentioned how expensive space is in New York, and it's also, we drive around here and I'm thinking, I see signs for 80 acres for sale. I'm thinking, oh my gosh, getting a block in New York would be a Herculean task. So there's really no ability to create more space, or very limited ability to create an empty chair. So it's one of our big initiatives is to pull anything that can be out of the clinic. And we'll see how it goes, right? Because I think, you talked about they're, even though they're comparatively could be viewed as the same kind of people that could work remotely, they support people who are there every day. So balancing that and physically moving them, I mean, it doesn't sound like a lot. I'm moving them about 30 blocks, but 30 blocks in New York is like 40 miles here, So, so we'll see. That's the goal. And as was mentioned, the folks in the clinical environment seem to get it more. And if I can recover some of that space and make it clinical space, revenue-producing clinical space, it's going to benefit everybody. That's our goal. We haven't done it yet.
I'd say, so you mentioned a couple of things. One is a hybrid work schedule. The other is shared spaces. I haven't seen the hybrid work schedule really change in the hospital, although I may not know all the intricacies of that, but shared space I've seen increase a lot. I mean, when you talk about building a hospital or anything healthcare related, healthcare construction's gone up 32% in the last 2 years. Mm-hmm. So with the cost of that, I have seen a lot more offices being shared by people as opposed to having an office for this position and an office for that position. Those places are getting shrunk down as much as possible, mainly due to cost.
Yeah, we're seeing a lot of collaborative space. So that really leads towards less hard walls, more open work environment. So even where we do have those offices that are dedicated maybe to the president of the campus, glass storefront, where they are more interacted and more connected to their teams, a lot more flexibility around that collaborative environment versus necessarily hybrid, because like you guys said, we can't really go hybrid in a hospital that operates 24/7. And then on the clinician side, or the clinic side, you go over to primary care and specialty care. They are looking at ways to save that space, because just like Doug was saying, they're really focused on where can we maximize our patient care space. And it's even physicians have a mindset of less necessarily dedicated space and more collaborative space, because they're pulling the rope in the same direction.
Any other questions? I know Nicole's got the mic. Looks like we have one over here.
Can't look that way.
Happy to talk about football too.
Chiefs? What? We're going to talk about Chiefs.
Go
How about the
Birds.
Broncos?
Go Birds.
Sorry. Go Broncos. A lot of the conversation that we have around space is about occupancy. So what type of systems or surveys or technology are you using to manage, first of all, get the data of occupancy data and then manage it over time?
So we're better at that in the research institute than the clinical institute because of the indirect cost calculations. I'd say Mount Sinai is among, if not the most sophisticated I've seen at doing that, probably because of the economic pressures. But we've got, we use the building model to identify who and what kind of space is in the research institute. I plan to extend it across the whole clinical environment. But what's fascinating about how we use these data is twice a year, the principal investigator gets a report of their space utilization. And once a year, they sit down with the dean and have to justify it based on their research productivity. And there's objective standards for that. That last part I have not seen at Mass General Brigham or at CHOP. And I think that's very, very sophisticated. And if a researcher is not at the levels of academic productivity that they expect, there's a conversation about it. If it happens 2 years in a row, they start talking about how do we recover your space. And the opposite is true as well. If they're very productive, they start saying, what do you need? And I think we need to get to that point in the clinical environment. I can tell you that I'm a firm believer in the master planning process, and I've done one, and I'm in the beginnings of one at Mount Sinai. At each of the other places, the Inova folks who are here today were really helpful in assessing the utilization of the spaces. In the cases, they do other things too, but in the cases of my master plans, one of the services that they were able to provide was what's called a hospital space assessment, where you go in and you look at those qualitative aspects of the space. Is it the right occupancy and the right the right chassis? We talked about some of the older buildings. We can use the quants to tell us whether or not the throughput is right, and that's an important part of it. But then there's also, do you have the right stuff and the right kind of infrastructure? And that's the space assessment as well. So I think that, it's an and, not an or.
So we've used a product in our new administration building. It's called iOffice, and it's not healthcare based. It is corporate office based. They were just acquired or merged with Aptura. So I can't give it a glowing recommendation just yet because we haven't stress tested it. When you're only at 33% occupancy and they can book anything they need and they can utilize the offices as needed, you really can't stress test it. But the goal was to engage that system. We interviewed a handful to make sure they aligned with our security and compliance IS requirements. That was the one we landed on. So far, it's working well. We've spread that to one of our education buildings in Temple as well. So it's something we're working through. We're learning a lot as we go. I've been really pushing towards a CAFM system for all of our facilities, so we just have more real time, because right now we do all that manually. I have 2 folks on my team who do all of our electronic data management, so all of our documents for all of our facilities along with our Medicare cost reporting, which break each of those facilities out. And much like Doug was mentioning in our master plans, we try to have a master plan for every campus. So as those master plans move along, the evaluation of the chassis and of the hospital is completed, but 90% of the time it's always a demand for space. I think our biggest challenge is our hoarders and folks that see an empty space claim that as theirs. And next thing you know, when you need to relocate them, they're like, well, where are you going to put me and how are you going to pay for it? So it's one of those give and takes within a healthcare environment.